Good morning, HARC. Welcome to the second day of HARC 2023, 15th year of this conference, which is kind of astonishing. I know people will continue to come into the room, but I'd like to get the introduction started. It's unfortunately, again, virtual, although that does make it easier for people to be at leisure in their office or home. But it does also detract from the possibility of people interacting with each other at such a meeting. And so I do want to encourage people to reach out and email people if you see potential connections. And over the course of the different sessions, please to reach out to people and make connections. New collaborations are really part of the goal of such meetings. Another couple of announcements before we introduce Tim. This year, the HARC is partially sponsored by the journal, Health Literacy Research and Practice. Tim's on the editorial board. I'm the editor, and it happens that anyone who comes to the conference can have a waiver for their author submission fee by using the password HARC 2023 on the website. So if you it's kind of a bonus for having come to the conference as well. So with that, let me turn towards Tim. Is a professor of computer science, and in particular has focused is basically an international expert in human-computer interactions. Today, we asked Tim to focus in particular on this exploding space of large language models, and Tim will be able to describe this. And really, instead of telling you all about all of his accomplishments, I'm going to let Tim take it over, so that people don't have to just hear me blather about him. Our collaboration goes back, I think, like 20 years or so, which means that we must have started to do research together in our teenager years or something like that. I'm not sure exactly. Maybe we were 20. Okay. And with that, I'm going to hand it over to you, Tim.
Thank you, Michael. Great. Well, it's a pleasure to talk to everyone, although I can't see all of you. But today I want to talk about large language models and chatbots in general, and the promises and perils they pose for patients and consumers, but particularly those across the health literacy spectrum. That's of most interest to us. And I'll close my talk with thoughts about many of the research directions and opportunities that this area holds for all of us doing research in health literacy. There's really a huge space of opportunities for us to pursue. And hopefully we'll have some discussion about that at the end. Okay, so there's several large language models that's been available over the last few years, including chatbots available to the public. But one that's received the most attention has been ChatGPT, both the public and the research community. So as I'm sure everyone knows, it was released just over a year ago and set the record at the time of the fastest growing platform ever, with currently something like 180 million users. What's equally amazing is if you look in the research space in PubMed, just within the last year, there's been over 1,500 articles published that either use ChatGPT, evaluate ChatGPT, or mention ChatGPT in the research that's done. So this is really an exploding area of research interest. So what does this have to do with health literacy? So tools like ChatGPT could be revolutionary for these patients and consumers on the lower end of the health literacy spectrum. It does an amazing job of simplifying medical documents. If you attended the panel yesterday, you would have heard some of the current research that's being done on that. It does a great job of explaining medical concepts, providing tutorials, even doing things like meal and nutrition planning. I tried yesterday just asking it for a lunch for someone on the DASH diet, and it not only knew what the DASH diet was, it generated a recipe that was perfectly in compliance.
I'm sorry, Tim.
Yes.
I think we had a little glitch there. Could you share your slides again, please?
Oh, sure.
Thank you.
Was that?
Perfect.
Oh, you missed all my intro slides. I don't think there's anything of particular importance so far. Okay, so yes, ChatGPT and large language models in general are extremely beneficial for patients, especially those on low health literacy end of things, because it can do such a great job of simplifying text and doing a wide range of functions. And just within the last couple of weeks, released to the public is a ChatGPT interface to GPT-4V, which lets you upload images and ask questions about them. So I took a random medical illustration off the internet, uploaded it, and asked ChatGPT to describe it, and it did a pretty good job of recognizing that this is a heart, describing features of the illustration, and recognizing that there was a medical procedure that had been done and what that medical procedure was. So these things are quite amazing, as I'm sure all of you know. The problem and the peril, of course, is that these tools make mistakes. They hallucinate, they fabricate information. And if you're asking for medical advice, assuming it gives it to you, these mistakes could be harmful or even fatal if they're blindly followed. And the argument that I'd like to make today is that low health literacy patients are at particular risk for these harms. So we don't have empirical studies yet demonstrating this. That's another research opportunity, but lots of related studies that I'll survey today. So I want to talk about the risks that large language models and chatbots pose to patients and consumers, particularly those with low health literacy. I'll talk about some potential solution paths for addressing these risks, remediating them, and then I'll close with a research agenda. So of course, there's been a huge amount of work on AI safety and innumerable meetings and summits and regulatory action worldwide. This is just yesterday, the president issued an executive order on AI development. But I'm not going to talk about that. What I want to focus on today is the literature from a health communications research perspective, and what happens in detail when somebody with inadequate health literacy sits down at a computer and asks for medical advice. So first, what's the evidence that chatbots have caused harm or can cause harm to patients and consumers in general? So I don't know of any epidemiological studies yet. Hopefully in the next year or two, they'll start to come out. But there's a couple of anecdotal stories like this one, where supposedly a man became isolated and spent more and more time talking with a large language model supported chatbot. It supposedly told him increasingly disturbing information and encouraged him to commit suicide, which he did. But this is just anecdotal information. What's the scientific literature? So I'll cover 4 categories of evidence for harm. So first is, can chatbots provide medical advice that could be harmful? And if it does, would people actually follow the advice that it provides? Another source of evidence is around, do any of these bad advice, is it the result of just the chatbot accuracy, or is user error play any role in this? So even if we had perfect chatbots, is there still the potential for harm? And then finally, are these risks greater for those with low health literacy? And I'll drill down into several sources of evidence for that. Okay, so can chatbots provide medical advice that could be harmful? So this is one of the areas in which there's been many studies done so far, in which individuals in a particular area of medicine or healthcare will pose a series of questions to ChatGPT and then rate the responses that come back for accuracy. And these studies demonstrate response accuracy ranging from 4% to 100%. There were also similar studies done with conversational assistants like Siri and Alexa done prior to this, showing that their accuracies range from 8% to 86% on giving correct advice back for medical queries. And I know of very few of these studies which also assess potential for harm. This is one of them. This was not laypersons asking questions, but health researchers asking clinically well-formed questions. In this case, it was GPT-4. And in this case, they found that GPT-4 only provided correct responses 41% of the time. This was also one of the few studies that looked at repeatability. So they asked the same questions of GPT-4 multiple times on multiple days, finding that we got inconsistent responses day after day, so low repeatability. And even with these well-formed queries, they found 7% of them of the responses were deemed potentially harmful if they were acted on. So again, this is for layperson queries or queries from low health literacy participants, the rate could be substantially higher. So this is a study that I did in my lab a couple of years ago, assessing conversational assistants like Siri, Alexa, and Google Home on their responses to medical queries. They don't use large language models, but it's illustrative of the kinds of mistakes that users can make in interacting with these conversational assistants, which I think is still informative for how they may interact with ChatGPT and more current chatbots. So the study was designed to show the worst that could happen if you asked Siri for medical advice. So we designed scenarios that were intentionally complex and which, if you took the wrong action in the scenario, would lead to harm. So this is an example of one of the tasks. So we would have participants come into the lab. We'd give them one of these tasks on paper. They would read it until they understood it. We'd take the paper away and say, okay, now ask Siri what you should do in this scenario. And they would often have to make multiple attempts until they finally felt that they had actionable information. We would ask the participant, okay, what would you do with that information that Siri gave you? And they would give us a response. And then we took the scenario and the participant reported response and give those to clinicians to rate for potential harm. And the harm scale was an HARC. It was a scale from HARC that went from no harm to death. So in this study, we had 54 participants with generally high literacy. And participants had to work at this. On average, they had to ask the question 5 times before they got an actionable response. So the results were a little over half the time they just gave up. They felt that they couldn't get actionable information, but 43% of the time they did, and they told us what action they would take. The clinicians found that on 29% of those responses that they were potentially harmful, and of those, a little over half were potentially fatal if they took those actions within the context. So this is one of many examples. For the example I just showed you a minute ago, you're taking OxyContin, and you want to know if you can go drink alcohol. And so the participant does a pretty good job of summarizing the scenario to Siri. And Siri completely misunderstands it and comes back with basically a garbage response, which the participant takes and runs with. They say, I can drink all the way up until 10 o'clock. Is that what that meant? They asked the researcher, and the researcher says, that what you think it was? Yeah, I can drink until 10, and then after 10, I can't drink. And then when we ask the clinicians to rate what's the worst that can happen if you drink alcohol while taking this medication is pretty severe. So we collected a number of scenarios like this and analyzed them for what caused the sources of harm I'll talk about in a minute. One of the interesting things is we looked at differences among these conversational assistants. And what we found is Alexa did the best job at not responding to out-of-band queries. That is, it refused to give responses to medical questions that were outside of its area of expertise. And because of that, people were very unsatisfied with it, rated it the lowest on satisfaction. Whereas Siri was always helpful, provided some kind of response most of the time. So people were most satisfied with it, but of course it was the most likely to kill you. Okay, so we talked about can chatbots provide medical advice that could be harmful? Absolutely. Would people actually follow this advice? So I'll give you some sources of evidence that they might. This is a couple of surveys that were done about 3 years ago, looking at information from Dr. Google. So just searching on the internet for health information. The first survey was of 1,000 French adults. Half of them said they use the internet regularly for health information. But interestingly, 30% use the internet for health purposes instead of seeing a physician, they reported. And a third of them acted on the information they found to change their medications or health behavior without talking to a health provider. The second study was of 1,000 Polish adults. Again, a majority used the internet for health information. 7% reported taking a drug or changing their medication based on information they found on the internet without consulting a physician. So this is just from searching on the internet. A more recent study looked at use of ChatGPT. So this is a survey of 600 adults who said they use ChatGPT regularly. And one of the many findings of this study is that 78% of respondents said they were willing to use ChatGPT as is for self-diagnosis of a medical condition without consulting a health professional. So there's some evidence that people would follow the advice from a chatbot were it to provide it. Another question is, does user error contribute to unsafe chatbot medical advice? So even if we have chatbots that don't make mistakes, users may still be complicit in providing incorrect information or misinterpreting their results. So this is the results from the series study I talked about a minute ago that we did in our lab. And we took every case in which they provided harmful medical advice and categorized whether it was due to the conversational assistant alone making a mistake, whether it was due to the user alone in providing incorrect information or misinterpreting the results, or it was some interaction in both. That is, they were both complicit in the bad outcomes. And what we found is that the conversational assistant alone was only responsible for 30% of the harmful advice. In all other cases, the user was at least partly to blame. So either misunderstanding the scenario, leaving out key information like not mentioning a comorbidity or medication that they were taking. Sometimes they would decompose a complex problem into subqueries and ask the conversational assistant for each of the pieces of information and then not properly reintegrate it. So we saw a number of different kinds of errors that users make in their interactions, in this case with Siri, Alexa, and Google Home. But it's indicative of perhaps the kinds of errors they might make were they to use something like ChatGPT for medical advice as well. So in thinking about the kinds of errors that can occur, we shouldn't just be looking at chatbot accuracy, but at the interaction between patients and consumers and the chatbots. All right, so finally, are all of these risks, are they greater for those with low health literacy? Perhaps of most interest to those of us here. And so for this, I want to drill down into several additional sources of evidence. User inability to validate the advice they get from chatbots, misplaced trust in chatbots, looking at the understandability or readability of output from chatbots, speech recognition errors, and then errors in formulating the prompts or queries that are given to chatbots. So inability to validate chatbot advice. If you get bad information or if you get any information from a chatbot, it's important that you be able to validate it against other sources of information to determine if it's actually made a mistake, if it's hallucinating, or if it's correct information. If we look at the standard definition of health literacy, sort of by definition, individuals on the lower end of the health literacy spectrum have a diminished ability to find and read and understand health information. So they have a diminished ability to, in fact, validate information from other online sources from the internet or perhaps other chatbots. So what about misplaced trust? So several years ago, so this is one of the projects I collaborated on with Michael. This is one of the first projects we worked on together, I think. This is a virtual hospital discharge nurse that we wheeled up at the bedside for inpatients to review their discharge instructions. Patients could have multiple interactions with us before they went home from the hospital. So I'll say more about this in a minute, but what I want to focus on now is some of the RCT results. So we had 149 inpatients who interacted with the agent and completed the exit survey, and we found a significant main effect of health literacy on trust and a trending interaction between health literacy and number of interactions on trust. And in general, low health literacy participants trusted the agent more, and their trust in the agent increased the more times they interacted with the agent. And we found the opposite effect for those with adequate health literacy. So this is, of course, for the same agent, giving them the same information over time. So all things being equal, low health literacy users perhaps had misplaced trust in the agent. So what does this have to do with the actual use of a chatbot? So this is a recent survey of 600 adults who reported using ChatGPT regularly, and they found that trust had a significant direct effect on not only stated intent to use the chatbot, but actual use of the chatbot. So this is not just for health, this is for all uses. But it's evidence that trust is a driver of chatbot use. And we just saw that perhaps low health literacy participants have a higher degree of trust in chatbots to begin with. So this is a potential area of concern. Right, how about the output from chatbots? Are they producing text or speech that's understandable by folks at the low end of the health literacy spectrum? So this is another area where there's been a number of studies done looking at the reading level or quality of text or patient education materials generated by ChatGPT in particular. So for example, this first study, they took texts that had been authored by surgeons for patients regarding the risks, benefits, and alternatives for 6 surgical procedures. They compared this to text generated by ChatGPT for the same topics, rating the text using Flesch, Kincaid, Gunning, Fogg, Smog, and other standard measures of reading level. They found that ChatGPT was producing text at a grade level of 12.9, which did much better, significantly better than the surgeon-generated text, which was at a reading level of 15.7, but still, of course, all of this well above the recommended level of 6th to 7th grade. Now, of course, there's a simple solution to this, which is you simply ask ChatGPT to produce its output for someone with low health literacy, and it does a reasonably good job of simplifying its text. But this is something else that we would have to expect low health literacy users to know to do and know how to do when they're interacting with the chatbot. So in my personal experience in developing conversational agents, I've found that individuals with low health literacy really prefer speech-based interfaces to text-based interfaces. They'd much prefer to hear information spoken to them than read it, and they really don't want to use a keyboard. So ChatGPT now has a speech-based interface on its mobile app, but there's evidence that speech recognition systems make significantly more errors with underrepresented populations, such as those with low health literacy. So this is a recent review article on biases in ASR systems, or automatic speech recognition systems. They reviewed studies indicating that speech recognition errors are higher for non-white races, those with non-mainstream accents, or second language speakers. So this chart here, for example, is from one of the studies they cite. It's examining ASR systems from Amazon, Apple, Google, Microsoft, and IBM. And so I don't know of studies that have looked explicitly at high versus low health literacy, but ASR systems do make more mistakes. They have higher error rates for populations they weren't trained on, and that likely includes low health literacy groups. And so, it goes without saying that if you have more errors on the input to chatbots, you're going to have more mistakes coming out of them. So finally, as I mentioned, users may make mistakes in their interactions with chatbots, so that even with perfect speech recognition, with perfect chatbot accuracy in providing responses, the user still may not provide perfect queries or prompts on the input. So going back to my series study that I talked about earlier, we found that in over 40% of the cases, the user did not provide a correct prompt, resulting in harmful advice. So maybe you've heard of prompt engineering, and if you've used ChatGPT a lot yourself, you know that there's an art to constructing a query to a large language model to get it to produce the exact response that you want. So this is being increasingly recognized as a new set of skills that need to be learned. And the problem for individuals with low health literacy is they already have a number of skills they're struggling with to get the information they need. And now this is an additional complex skill that they might need to learn if they're going to use chatbots to get health information. All right, so what are we to do? How do we help individuals across the health literacy spectrum reap all of these benefits without harm? So there's no silver bullet, but I'll mention several possible directions of development and research for addressing risks. So the most obvious fix is to stop them from hallucinating, increase their accuracy. This is the billion-dollar investment that the large companies are making now on commercial systems to get general large language models to continue to improve the responses that they give. But there's also significant work underway to build large language models specifically to answer medical queries. They're continuing to improve. This is one of the most recent results published. But even in this one, when they compare it to clinicians, the outcome is, it still remains inferior to clinicians in the responses that it's giving. But these authors also evaluated not only accuracy, but likelihood of harm resulting from errors, finding that their best model produces results that could cause harm about 6% of the time, which is about the same as the clinicians they had rating their same queries, which of course brings up the question that's been asked in many areas of AI, whether we should hold our AI systems to higher standards than the human experts they're supposedly replacing. In any case, there's a huge amount of work going on right now to improve the correctness and verifiability of the information that these systems provide. So transparency and explainability in our context is the ability of a chatbot to tell you how it arrived at its answers. So presumably, if you know where it got its information from and how it formulated its response, you'd be less likely to follow bad advice. So this is a very complex task, especially for black box models like neural networks. It's a very active area of research in machine learning. I'm not going to say more about it, except that I don't know of any work that's currently focused on producing explainability or explainable results for low literacy or low health literacy populations, which is a research opportunity. So another solution to reducing risk from chatbot-generated medical advice is to find ways to constrain how the user uses the chatbot or what they're allowed to ask the chatbot. So in the work that we've been doing in my lab for many years now, we've been developing interventions for very narrow areas of health education and health behavior change counseling, in which we produce what we call an embodied conversational agent. It's an animated character that's simulating face-to-face conversation. So these are constrained to a particular area of healthcare. The agent typically leads the conversation, walks the patient through the education content. And importantly, when it's the patient's turn to say something, we fully constrain what they're allowed to say and give them a set of choices that they can pick off of a menu. So most of the health-related chatbots that you see, certainly before ChatGPT, things like Wobot, also use this form of user input. So it looks and feels like a conversation, but we're really constraining what the user's allowed to ask. So essentially, we're doing the prompt engineering, allowing the user to pick from a set of prepared prompts. And importantly, we can validate everything that the system tells the patient for all possible queries. Okay, finally, a couple of other areas to reduce risk are in what I'll call grounding and in warnings. So we did a study on this also a couple of years ago to look at using these two techniques to reduce the likelihood that patients and consumers would act on medical advice from chatbots. So we used the same scenarios we used in our series study as the one I just showed you a few minutes ago. In this case, we used a fake chatbot so we could manipulate the responses that are provided to users. So we gave the participants scenarios that they would pose to the chatbots. The chatbot would provide advice that was manipulated in a couple of different ways, and then we would ask the participant what they would do after hearing this advice, and then rated that. One of the things we manipulated is grounding. So grounding is this process in social linguistics of how people arrive at mutual understanding of something that's said in conversation. So there's a whole protocol that we follow unconsciously. For example, there are acknowledgements called back channels where we say or nod our heads to show that we understood what was just said. Or the next thing we say is contingent upon what was just said is another way of demonstrating understanding. Or we can use explicit confirmation or explicit repair strategies to try and fix things that were misunderstood. Siri, in some of its versions where it has a display, does a simple version of this where it displays the results of the speech recognition before responding to it. So it lets you visually check that it understood your speech. So we use this as our form of a simple form of grounding, where we would either display the query that our participant gave to the conversational assistant, or we would display a mangled version of it with intentional errors to give them feedback that the conversational assistant did not understand what they just asked. So that was one manipulation. The other manipulation is whether the advice from the chatbot was followed by a warning that said you should talk to a health provider before following the medical advice. So the results were as expected. In the cases where the chatbot did not properly provide grounding, didn't provide the validation of the input, participants were significantly less likely to say that they would actually act on the chatbot's advice, and significantly more likely to say that they would seek further information or talk to a professional before they would act on the advice. And similarly, the warning had the desired effect in that if we gave the warning, they said they were significantly more likely to talk to a health professional before acting on the information. Now, I should say ChatGPT does a reasonably good job of providing warnings now. So when I gave it this example that I showed you from our series study, it gives a little bit of information, but it clearly says you should talk with your healthcare provider before taking any action on this. All right, so I'd like to close by talking about a large number of research opportunities, and hopefully we could, you have lots of ideas that we could discuss as well. And as we've seen, there's already been a huge amount of research with large language models in healthcare, but very little of it intersecting with health literacy. So of course I asked ChatGPT and it came up with a nice long list of possibilities, but I'll give you my own curated list. So there's already been a lot of research done using ChatGPT to generate patient education materials, different kinds of texts followed by evaluations of those texts. So for example, a study we did in our lab just recently was using ChatGPT and Stable Diffusion to go from a set of health education goals to an interactive narrative game to teach adolescents about HPV vaccination. We did this in a very short period of time with validation steps to let clinicians check over the information that was provided. But this was sort of a proof of concept of one way that these models could be used to generate patient education materials. Of course, large language models can also be used to evaluate patient education materials. ChatGPT supports 50 languages, so it can be used to translate materials or tailoring them for various populations. Other research opportunities are developing methodologies for validating the output from ChatGPT. If you're using it to generate patient education materials, it's important that it be carefully checked by clinicians before you ever put it in front of patients or consumers. So developing methodologies for letting you do this in a sound way is an important area of development. There's an immense amount of red teaming going on in AI models now, which is basically having testers test the outputs for accuracy and harm. Very little of that, or none of that I know of, is being done specifically with low health literacy groups. And that's something that we as a health literacy community could have a lot of input to in generating what those methods and evaluations should look like. Large language models could be used to assess health literacy, either by providing text or speech input from patients or consumers, or by generating tests or scenarios that you could use to probe health literacy. It's important. Another area of research is looking at the output from chatbots. We've looked at readability, but other dimensions of quality, validity, and bias for different subpopulations. As we talked about, assessing speech recognition errors by health literacy. The whole area of grounding is important to look at. So in our study with Siri, we just looked at speech recognition to display whether it was correct or not. But grounding in general is displaying what a system understands about what the user's trying to do with it. So not only the query, but perhaps what the user's intent is, what their context is, perhaps information about their background and medical history, their context of use, and what they plan to do with that information after they receive it. So if all of this information can be provided to the user, they may have a much better idea of understanding what they should do with the chatbot output. Identifying unsafe queries. So a lot of the red team testing is going into doing this, but there's a lot more research that can be done for identifying when is a query potentially going to provide advice that could cause harm, so it can be prevented. And then, as we discussed, looking at explainability and transparency specifically for low literacy and low health literacy users. And then finally, studies that are now important to do, looking at actual harm and potential harm in fielded systems. And then there's a whole nother set of research topics that have to do with how individuals with low health literacy use chatbots contrasted with those with adequate health literacy. So what kinds of mental models do they have about how the chatbots are actually working? How do they formulate prompts, and how are these different from those formulated by those with adequate health literacy, and how do they interact with chatbots? What are their conversational skills and abilities that they bring to these interactions? Their attitudes like trust, and how are those formed? When do they turn to a chatbot? What will they do with the chatbot's advice? How do they go about validating the information from a chatbot? And when would they seek professional help? So lots of potential here. So in conclusion, chatbots make mistakes still. Many of these mistakes are problems with user interaction. So even when we get perfect chatbots, we're still going to have to be concerned with how users interact with them, the input they provide, how they interpret the output, the broader context of use. These risks, I feel, are exacerbated by those for those who struggle with health literacy. And the main takeaway, of course, for everyone, but particularly for those with low health literacy, is don't follow the advice they provide. Talk to a healthcare provider. Thank you.
Awesome. Thank you, Tim. It's great to hear your summary of what's been out there and also what needs to happen here in this space. We're open for questions. I'm going to just start off with a few things. So one is this area of bias. It feels like you mentioned that some bias, but that there's also other biases. Like, you know, these systems, I think they're basically working off all the information that's available to them, but like the information that's available to them is full of, you know, the bigotry and sexism and, you know, of all the stuff that's on the internet anyway. And so I wonder if you have thoughts about the, and then it's just going to get validated against what's out there, you know. So concerns or thoughts about, you know, what's to be done about this, or is there anything to be done about this?
Well, including more underrepresented, you know, populations in not only the training data, but in the testing and the red teaming, I think is important.
So, but there's a kind of a derivative thing that, you know, as more and more of the content that's out there is actually generated by large language models themselves, won't there be like a circling firing squad? Like, won't they be validating against themselves at some point? Like at some point, maybe half the wiki pages out there will be written by large language models themselves. And so isn't there like a risk that this is just driving itself?
Absolutely. So it's up to us as a research community to identify these cyclic biases and point them out for correction. So how do you fix them? Well, you have to identify them first, but systemically, I don't know how to fix them other than making sure, again, your training sets and your testing are you know, represented across the spectrum.
Yes, and then in our space, as you're pointing out, that it includes the perspectives, the voices, the language of people with low literacy, and the way people ask questions. So let me just start with Carol asks, how should hospital systems focus on these large language models in patient education efforts and in staff training, is the question.
Well, so the number one rule is you never put anything in front of a patient generated by a large language model that hasn't been looked at by a clinician first, right? Because they can produce false information. So that should always be the top concern. So they're great at producing draft materials, and you should treat them as such. As far as staff training, I guess I would say the same thing, that they're great at producing draft materials, but they really need to be reviewed and corrected before they're used.
Yeah. Greg's asking, as Biden moves forward towards guardrails for AI, should we, as a health literacy community, be voicing our particular concerns? Any thoughts for how we could do that?
Oh, how to do that? Well, the what is, as I mentioned, one thing is ensuring there's a huge amount of red teaming going on now, which is testing of these models, but it's unclear to what extent those are including representative queries from underrepresented groups, or are done, say, in actual contexts of use by underrepresented groups. So I think those are important things that we should be considering. And how,
yes. So what are the, I mean, it seems like there's kind of like privileged pathways towards like, you know, who gets invited to these conversations at the White House and stuff. And so maybe how do we, I don't know what the right word for this is, infect those pathways with our concerns? I don't know, maybe that's not exactly the right verb. Thoughts?
Well, I mean, if we can point out some of these potentials for harm, potentials for you know, systemic errors by not paying attention to underrepresented groups, perhaps we can get their attention.
Yes, so I agree with Donna, who points out that health literacy folks need to be at the table. So you know that this has been the case already for quite a long time. That when people talk about user testing or usability, like that frequently people with limited education or limited health literacy are not included. We have a question. Thank you for the informative discussion. How would you suggest increasing AI literacy in the broader community to prevent the spread of health misinformation by AI?
Well, I'm going to sound like a broken record, but continuing to point out that these models are not perfect. They do make mistakes, potentials for harm. Perhaps we need to just get better about communicating this across the board. And you should not be following anything like medical advice, not be changing your medical or healthcare without talking to a medical professional first.
So, but this feels like a big like whack-a-mole problem, like this is gonna be popping up everywhere, and like, is there any better solution than just I don't know, maybe I'm asking you like a political action question.
Well, this does seem to have the attention of the government, and they're trying to put in guardrails and regulations. But as far as informing the public, I don't know exactly what's being done there or what we could do. Do you have ideas?
Yeah, maybe we should, as a health literacy community, write an open letter to the White House, or whoever's going to be the AI czar. That's kind of what's going to happen, I guess. Any entities that you could recommend for continuing education learning about AI or prompt engineering? I
can recommend some literature references. I don't know about continuing ed opportunities, but I'm sure they exist.
Yeah, so this is going to be an extremely rapidly evolving space too. So
we could have tutorials at next year's HARC.
Sure. I mean, we could have a live query right now if you want to share your screen, and we could just see what it tells us. Like, we could pose a question. We can ask Carol's question to ChatGPT.
Oh, all right. A live demo. Wow. Okay.
Yeah, exactly.
At least it's not it's not mine.
Well, it's not like a health information question, but we can still see what it recommends. You can just copy Carol's question.
Can you see that?
Yes, we can. Yeah.
Of course, you have to understand this could all be fake, but it's worth following up on.
So as you can see, it's pointing out all this information, and it looks as if this is all real, but we don't know yet how much of this is confabulated, really just fabricated. Maybe it's all real. Who knows? But we'd have to check.
Well, also, it's taking this query out of context. It doesn't know we're at a health literacy conference, so it's giving us all the technical machine learning courses, which is probably not what was being asked about. So we could try and contextualize it more in the health education space.
Yeah, you could stop it and just try again with say for people who are not computer scientists or whatever communication.
Health communication.
Sure. Fantastic. So it's just going to continue to do this. And it'll generate a lot of stuff, and some of it will be accurate even. Awesome. So, you know, yes, thank you, Maricel.
Still going.
Yeah. Sabrina's asking how to use GPT to train professionals to write and speak in plain language. You know, so you mentioned earlier, you know, that the scenario of having a first draft created in of a patient education materials, first draft, because then it's going to be reviewed, say, for accuracy, comprehensiveness, and things like that. But you could, in the query, in the prompt itself, in that first draft, also specify the reading level that you wanted it to be at least theoretically. We don't know what rules it's going to use for what qualifies as a reading level. It doesn't say, oh, I'm just going to do that off of, you know, this readability analysis system or that one. But it will generate a draft, and you know, so you can think of this as something that can make people more efficient, in theory. But I don't know. I think that I think it's something that also not just that it'll be reviewed by experts, but that we should be putting in front of patients. You know, like to actual usability testing to like learn how to do this well.
Mm-hmm.
So there's a full disclosure. It's your sister. Okay, Zainab, I don't know if you want to, if you can unmute yourself and describe this. Is Zainab allowed to speak? Maybe. Oh, you don't know if you can. Okay, well, if people can see in the chat, there's a new AI literacy newsletter that Zainab has put the link to. Okay, sorry, we can't unmute in this mode. Sorry about that. Maricel's, you know, has been advocating for some investment. Yeah, so trust, you know, thank you, Inga. So maybe I mentioned the issue, you spoke a little bit about the issue of trust in these things, Tim. And I don't know if you, because it does put this stuff out as if it's authoritative. So I don't know if you have more thoughts on this. You presented some data from one of our projects, but I think there's a huge research area to look into.
It is, and I have a hypothesis that you tend to trust results from speech-based systems more than text, and especially if you ask a system a direct question and you get a direct response without any hedging or uncertainty, you know, in an authoritative way, that you tend to trust it to a much greater extent than maybe you should. So I think it's a combination of modality and the way the answer is framed. So yes, it's probably higher for those who have lower levels of computer literacy and health literacy.
Yeah, so there was a direct question about this in terms of if there's like disclaimers and things like that. So one thing, maybe if you just take a moment, Tim, people know the brand ChatGPT, but just to maybe if you spend a moment or two, like how big is this space, different entities in this space of large language models, and how big is it going to, how many companies, like it, you know, I'm sure they take different approaches to how they present their information. I don't think they have warnings.
Largely. Oh, they do. I showed you an example of ChatGPT. If you ask it for medical
advice, that's within it. But like if at the beginning, if you say like, hey, don't do this while driving or something.
It's a blank screen.
It's a blank screen. Yeah.
It's no tutorial, no information, no warnings. Yes.
And there are dozens of these, right? Or
well, there's about 5 from the major companies, and then if you look in the research space, there's dozens that have been developed for research purposes, and then variants that people have produced for different specialized tasks.
Yeah. Fantastic. So I think this is really just going to be going to continue to explode. There's certain areas of the world that this is like going to be used a lot in, and one of them is in health. The health queries that are just exploding, and so we have to figure out how to approach this and get our hands around the possibilities here. There's be a ton to do, and it's going to intersect with many of the things we've been talking about, things like trust and mistrust. And I think any clinician who is imagining that they're talking to the patient with information that the patient doesn't already have a view to, like it's not like a one-way street anymore. Patients are swimming in information all the time, and it's back and forth all the time. So another would be like, I would hate to be a teacher at this point, university teacher or a high school teacher, and even because these things are, just being used by everybody all over the place, to generate stuff all the time.
Oh, absolutely. It's a big thing in academia. I stopped giving essay exams, take-home exams. This is no point.
Yeah, so people have had to be creative, how to still do assessment, and there's a large potential for fun work to be done, fun research in this space, and to figure out how this can be leveraged as a positive thing and not just as a bad thing. And I guess one final, I guess there's another question from the disease branch, from the infectious disease branch.
Studies on why groups trust AI chatbots more than others. I don't know about the why. I only know that some studies that I've done, and I've seen some other ones that show that some groups trust more than others. But the why question, I'm not sure. In some contexts, it could be because of a lower perceived stigma of talking about sensitive topics. That's been shown many times that if you're talking to computer systems, that you're more open with them because you don't feel judged. But other than that, I don't know why there's this source of difference in trust.
Yeah. Yeah, so I think that Marisol wants more. You're here, Marisol. So, but no, we need many more people like you, Marisol, and that's a long way of saying it. This is going to be not a topic that's going to go away anytime soon, there's going to be a whole policing effort. There's going to be a whole red teaming effort. Like maybe we can reduce some of the risk, but it's going to be an ongoing project. And I think it'd be fantastic for health literacy to lean into this, not just in many ways. In research projects, like research funding is going to probably blossom through this, into this space. I don't know what programs are going to get gutted to make it happen, but something's going to have to give because this is going to be so pervasive. So with that, Tim, thank you so much. We have other sessions for people to run to at this point, so I'm going to have to cut this off. And we hope to see people in other rooms in just like right now. Congratulations, Tim. Great to work with you.
Thank you.